The truth of the matter is that the reason I'm going last is he didn't want to because he said you'd all fall asleep on me. Yeah. His favorite word is spicy, so he said I had to make it spicy, and I don't know how I'm going to do that. But my role at the hospital is volunteer coordinator and one of the chaplains, and most recently I was asked to be patient advocate. So it's relatively new, and at our hospital we call the role patient representative. I think that possibly advocacy could be more fundamental, or it could be more complicated in how you interact with the patients. And I would describe my role as being more basic. So some of the things I'm going to be talking about might lead to more complicated issues, and then I'll defer to Larry, who has been a patient advocate for how many years?
13.
Yeah, so okay, that's what we'll do. But in the hospital, I try to make visits to the patients as they come in. It's impossible to cover every patient, but if there is a concern, then I'm always called. So I'm able to help the ones who have those needs. And patient advocacy is really a support, so it kind of blends into the other roles that I'm already doing. I heard a couple of you mention advocate while we were talking, so I think that most of you are advocates in your own rights in what you're doing already in your roles in your churches, in the retirement homes, in your businesses. But I would say that as a support, I was asked by the hospital to be attentive to what the patient needs are and to be able to resolve them and reactive to them. So that leads me to what are the qualifications of a patient advocate. And if you look under what I have written, which would be the last group of papers on your list, not really because we still have abbreviations and prefixes and suffixes, but there's really no qualification. You don't have to be have clinical training or a nurse, but I do surround myself by competency. So if I see a problem, then I'm equipped with somebody to report it to so that they can either give me advice or they themselves can correct the problem. I also, I would say my experience in patient advocacy came from our own personal experience in a hospital when my husband was there for a month. And I really didn't know how a hospital worked. I didn't realize that doctors came at certain times during the day, and if you weren't there, you missed it. My husband was very sick. He was highly medicated, and he really couldn't represent himself nor understand what the professionals were telling him when he came by. So I realized that he needed somebody to be there with him, to listen, to interpret, and just to be his advocate. So I saw the need and I understood the process, and I understand why some people who come in the hospital might be confused or might be anxious because they're not understanding what's happening. I think, was it Nena who talked earlier, that the doctor comes in and says something and then he leaves and you really don't retain what he said. So I think it really helps in the hospital. We have a couple people who follow up after the physicians saying, you know, did you understand anything? Do you need any more information? And if they do, then I'm able to go back and get the person who can re-explain it to them. Because the reality is most people don't want to be here. It's an interruption in their life, and they are anxious, sometimes confused. Usually when I ask them what I can do to help them, they say, get me out of here. So, you know, I say I'll try to expedite the process, but there is a process, and unfortunately, you'll be better off if you're released when it's time for you to be released so you don't come back beforehand. But some of the questions that I ask when I go in to visit a patient is, number one, are they comfortable? Are we taking good care of you? Do you have everything you need? Is your pain being managed? Are you informed? Is there anything we can be doing better? And that really opens us up for criticism. which is a good thing, because the reason I am employed by the hospital is that they do want to do the right thing. And sometimes the more personal interaction, people are more willing to share with me what their discomfort might be, even if it's with a nurse. And they don't want to complain to the nurse because then they feel they'll get bad care, so they'll tell me. And then I, in turn, can either explain to them what their perception or misperception is, or maybe talk to the nurse and explain to her that this patient needs a little more attention. So some of the people that I utilize as my resources are the nursing supervisors. I try to go directly to the nurses themselves because they're the ones that have the most contact, and if I feel that I wasn't able to find a solution, then I'll go over top. But for most of the time, I need to say too, when I visit a patient, what I hear is, we are taken such good care of. We love this hospital. The private rooms are great. I hear all kinds of compliments. So usually I'm kind of in and out of the room, but when there is a concern, we try to take care of it, because obviously we want to take care of it in the hospital. If the patient leaves, then it becomes more complicated. It becomes a grievance, and that just involves a little more time and energy. One of the examples of something that happened the other day I thought was really interesting. It was so easy to fix, but had it not been corrected, it could have led to a problem. I got a call from a family member. They were actually grown children, and their mother was in the hospital. And their father was acting as advocate. He was in the room with her all the time. But when the physician came in, I guess he was talking more directly to the husband, who was kind of overbearing and not representing his wife very well. So the children were concerned, and they said, could you please tell the doctor to talk directly to our mother? He probably thinks she doesn't understand, when in fact she just has a hard time hearing. So if you make sure her hearing aids are in and she can hear you, she really has something that she wants to say to you, instead of our father speaking over her. So I was able to talk to the physician, who realized that there was a hearing issue and that she was capable of understanding, and the problem was fixed. So sometimes it's just so easy. And sometimes it's a matter of me getting somebody a warm blanket, or sometimes they just want to complain about the vegetables being crunchy. Or I can go in the next room and they tell me the vegetables are too soft. So it's just a matter of trying to keep everybody happy sometimes, which is impossible. But I see the two of them laughing at me back there. One of the more agitated patients was an elderly woman, and she was taken to a test. And while she was gone, the nurse thought she'd tidy up her room, to help her, make her more comfortable. And when the woman came back, she freaked out because everything had been moved, and that made her uncomfortable. And housekeeping are the ones who called me to come deal with the problem, because she was out of control. This woman just could not be calmed down. And after we talked and explained it to her, and the nurse put everything back the way it was, everything was fine. So, sometimes the issues are as simple as that, and sometimes they get a lot more complicated. We'll get to that part. Sometimes it's just a matter of saying, I'm sorry that it took so long, or I'm sorry you don't like your food, or I'm sorry we served you too much food. But again, some of the things are really easily corrected. I am looking at the second page, and that talks about HIPAA and privacy. I think we've covered that enough that you understand that everybody's role here is shadowed heavily by HIPAA and our understanding of it. And the Patient's Bill of Rights, we really, if you read through them, I'm not going to go over it, but the patient has the right to be treated in a certain way and has the right to be represented in a certain way. And our hospital is well aware of that, and we have the Patient's Bill of Rights at the beginning when anyone comes in and is registered, and we carry it through and make sure that it's executed. I think I'd like to end this. I thought this was really interesting too. Again, when I was talking to Larry about my role, I said that I'm really in my limited role as patient advocate, and I don't know if you want to talk a little bit more about what you've done in your role. But I was visiting a patient and going through all the questions that I normally asked, and he was not very well groomed, and he had really bad grammar, and he wouldn't even look at me when I talked to him. And so I thought he really wasn't paying attention to me anyway. Sometimes people are just so sick of being visited and asking questions that they just want you to get in and get out. So I went through it all, and when I realized he really didn't have a need for me, I said, like I always do, is there anything I can do for you before I leave? And he said, you could smile at me. And I said, okay, that's easy, I can do that. And then he said, any God-loving person is capable of sharing this gift. And it just made me laugh because it gave me a whole new perspective of what a glorified hostess is. And sometimes, somebody just needs a smile, a little bit of encouragement, or an I care, or we all care, and it makes all the difference. Does anybody have any questions?
In the area of HIPPA and the chaplain, sometimes there's a struggle, especially when the resident comes from a retirement home, where all the knowledge of that resident, we're all under confidentialness of that. That's not a good word, but we all have that confidentiality signature. Come to hospital, and sometimes the understanding of the knowledge of that patient is not forthcoming. That prohibits to some degree the role of the chaplain being able to help that person. That person may be going through an operation, may have had an illness, whatever that is. That's a struggle, and I don't know always the answer. You understand where I'm coming from?
Are you saying you coming as a chaplain from
Right.
the, okay, and then coming here not getting the information?
Yeah.
And the patient's not able to share it with you?
Well, sometimes when they're not capable of doing it.
Okay,
You understand?
you're right.
If you can get family to release you to give that information. HIPAA's law says the need to know. When a nurse is leaving the shift at 7 p.m. and the nurse is coming on at 7 p.m., the next nurse needs to know. Respiratory therapist needs to know that. So there is a law that is okay to share, but you're in a different facility, and that's where the barrier stops. But if you get that release from an alert patient or the release from the family of that not alert patient, and give that. Give that, whatever that information.
If you came to my facility, then you couldn't get that information.
If I, as a hospital chaplain, came to your facility, I would not be able to get your information unless somebody allowed me to have it. Same way with you coming to ours. Because it's the institutional barrier that breaks down. Within the institution, we have the need to know.
The complication is often we cannot meet their needs, or it's difficult to meet their needs because of that lack of information.
But if you get patient release or family release of information, that they allow you to share something or to gain something, then it's okay.
Yeah, I understand that. I'm just sharing the complication that often is in
HIPAA makes things complicated.
Yeah.
I think we all
And
agree
we
with that.
overcomplicate HIPAA. I mean, yes, HIPAA will put you in jail and for 10 years optimum and $250,000 fine. Yes, they will. But there's certain things that we run and don't give enough information because we're afraid that we've crossed the line. So we need to be careful. But if you get consent from the proper people to give information or to gain information, you're good.
Larry, is that a verbal consent?
Sometime it has to be written, according to what I mean, sometimes it's like family information, or it's medical information, or it's legal information, or spouse information, or it's a son coming into town information. It's like there's all kinds of stuff that we as a hospital need to know, or you as your institution needs to know, or a person, even a pastor coming in is going, I have something I need to share with somebody. I don't know who knows or cares. Or I need information as a pastor or family member just to do their job. So it gets sticky.
I have a question. Am I allowed to ask a question from up
I
here?
guess you are.
If the supervisor from the nursing home could get the information from our facility, and then maybe you could speak to the supervisor before you came in, is that possible?
Yeah, yeah. Usually the supervisors know their limits and their boundaries and know what they can share.
It's just a complicated process.
It is,
Mhm.
yeah.
It's not gonna be solved, just like when pastors come in. We gotta be very careful what we
Yeah.
say to them.
Right.
Right.
You know, if, for example, the POA says no information given to your clergy, we're closed down.
And I say to clergy, don't ask a nurse information. Ask the patient, ask the family. But don't ask us as possible employees, we can't get it. But they can ask an alert patient. They can tell or not tell. They can ask a family member. Sometimes we say you can get the information, and some information is just not even necessary to know. It's just we have a lot of curious people coming in going, well, I want to know, you know, 'cause then they go share it back with churches and family. That's not a good thing.
Yes, Glenn?
I'm responsible for the prayers in the congregation. I'm responsible for the prayer chain throughout the congregation. I'm responsible to report to the congregation about hospital calls I make. And my number one rule is I tell them what I'm allowed to tell them, and the patient giving me the primary information is in control. And sometimes it's very hard to do, but it works. Because I find that in that silence, if that's the case, if people find out this is an unspoken, the next week I see that person, they'll give me a little bit more information, and they'll feel a little bit more comfortable in sharing what's going on. And we tell them what they're allowed to tell them, because we always said that the patient is the one in control, and that seems to have worked with us.
Yes, Thomas?
I was just questioning, isn't it true that a family can only give somebody information if they have consent from the patient? And if the patient is not able to give them
Right.
consent at this time, he must have given them consent beforehand.
Yeah.
Isn't that true? Otherwise the family can't give it.
Well, like a family member needs to have a HIPAA release form, or they need to be the power of attorney for health care or something like that, you
Before
know,
they can give.
or even gain information.
Yes.
I just wanted to comment because I think both you and this morning, Nina, is her name?
Nana?
Yeah, Nana, gave a really good point about the family being able to contact you and say, there's an issue with our mom and our dad. So my question is, when people come into the hospital, patients, is the family advised of who they can contact if the patient is having any issues? Just a question.
I don't know if we have it listed, but if the family would talk to the nurse with a concern, the nurses should know that who to call.
I bet it's in your patient information packet,
Yeah.
but they don't read it. But everybody gets one.
Because it's such a good point. I mean,
Yeah.
you know, if you're having an issue with your parents, and you can call someone and say,
Mhm.
rather than go through the nurses, because
Right.
Yeah.
sometimes you can tell a nurse, but.
Yeah. And lots of times the nurses are thrilled to call us in because they don't have the time to be dealing with it.
Right,
Yeah.
exactly, that's what I was gonna say, they
Mhm.
just don't have the time.
Mhm.
By the Joint Commission law, we have to give that information to every patient. Now, it's in a little plastic bag that's in the trunk of a car somewhere, okay, because the spouse took it home. But we have to hand that, all the list of people to call. But sometimes, you know, they don't flip through it and use it.
I know that sometimes on my visits, and I tell the people who I am and why I'm there, they'll say, wow, we didn't get this treatment at another hospital, and I know that they did. So it just goes to show you that sometimes they don't read all of the information that's available to them.
Sometimes they can't, they don't.
Right,
They can't.
right.
You don't feel like reading.
Anything else? Okay, I know you have some things to say.
Yeah, just to kind of wrap it up, well,
Thank you.
Thank you for your time today, listening all.